All right. Good morning, everybody. We are at 8 o'clock. I know people are still kind of signing on here. And I'll go ahead because we've got a pretty packed agenda today, and I'll just hand it over to Dr. Rao for introductions.
All right, thank you, Jesse. Thanks to everyone for joining us again. We're kind of on the home stretch here. I think there's only 4 more sessions, including this one. So we've got a really great presentation from Liz and Danette this morning, as well as 2 great cases. And here are some disclosures that you can read. I think the relevant ones this morning, maybe from Chris in particular. Person-centered language, we've done quite well with this, and I think we will continue to do so, but please review that at your leisure. Liz, please go ahead.
Hi, everyone. Good morning. I will be kicking off this didactic and then passing it off to Dr. Conklin. So today we're going to be talking about, I like to say body size and referring to bias and discrimination. So these are the 3 objectives for this morning. List and describe a minimum of 3 well-known findings related to bias and discrimination against people with increased body size. Number 2 is list the impact of bias and discrimination upon the physical and mental health of people with increased body size, and describe strategies for addressing mental health issues as a cause and consequence of increased body size. So weight bias and stigma. So the World Health Organization actually recognizes this, and they have actually put out some guidelines and things to consider. So weight bias is defined as negative attitudes and beliefs towards a person because of their weight. And weight stigma, the World Health Organization defines it as a social label that's attached to a person who experiences prejudice. And so you can imagine some of the types of prejudice someone might experience based off of their weight. And this is exclusion, whether it's social exclusion, marginalization, discrimination, for example, in the workplace, or not even receiving adequate health care. So what does the literature show with weight stigma and health behaviors? So there's a recent systematic review and meta-analysis that does show that weight stigma is associated with the following. And so these are with health behaviors. So it's associated with increased disordered eating. It's associated with increased comfort eating, increased alcohol consumption, and increased sleep disturbances. And so we know that these are all negative health behaviors, which can lead to other health outcomes. So weight stigma is associated with these behaviors independent of an individual's BMI. So that's important to consider it. So there's another study out there that then looked at mental health outcomes. So looking at weight stigma and mental health, it's associated with all of these. So weight stigma is associated with decrease in quality of life, more depressive symptoms, more anxiety symptoms, increased psychological distress, increased body image dissatisfaction, decrease in self-esteem, and decrease in well-being. And it's important to note that these individuals who did do this systematic review and meta-analysis, that these associations were not moderated by age, gender, or race ethnicity. Another thing to consider, and this is an article by Wu, is when talking about weight stigma, looking at some of the physiological outcomes. So experiencing a high frequency of weight stigma, this article showed that there's an increased risk for developing type 2 diabetes. It was also associated with higher A1C levels and sustained salivary cortisol elevation. So what can you do? Well, one of the things that you can do is something that we've been reminded every single week, and that's talking about language. So using less stigmatizing language has been shown to be very effective. So rather than saying obesity or using terms such as fat, saying things like increased body weight, or even saying someone's BMI or just higher BMI. So we've talked about this before, but using person-first language. So just saying a person with increased body weight rather than saying this obese person or obese patient. And then for patients, one thing to talk about is just asking their permission if they want to talk about their weight. A lot of people are very sensitive about weight and they might not want to discuss it. So asking for permission, and this is things that we've heard about from Jim when he talks about motivational interviewing, is asking for permission. And then when you're talking about someone, to not give blanket statements when you're giving them advice. So a blanket statement would be something like, maybe you should eat less fast food, but giving them very specific recommendations. And then we've also talked about the importance of SMART goals. So a SMART goal is focusing on something that's very specific and measurable. And rather than giving a general statement like you need to lose 50 pounds, giving them something very specific. Can you walk 30 minutes 3 times a week for the next 4 weeks? So these are things that have been shown to be very helpful to support patients. So what I'm going to do is I'm going to pass this over to Dr. Conklin.
Thank you, Dr. Beverly. Good morning. So in this presentation, I'm going to talk about the different types of weight stigma, point out some of the statements on 2 weight stigma questionnaires, and then lastly, briefly review some of the non-pharmacological interventions that are used to treat weight stigma and unhealthy eating patterns. So first, implicit bias. These are attitudes or stereotypes that affect in an unconscious manner how an individual understands them and acts on them. An explicit bias, these are outward attitudes or stereotypes that generate intentional, conscious discrimination and prejudices towards other persons, such as those who are overweight or obese. So other types of weight stigma, the experience of a weight stigma situation. This denotes how an overweight or obese individual perceives negative attitudes or inappropriate behaviors directed towards him or her because of weight. In an internalized weight stigma, this denotes a measure of an individual's belief and stereotypes relating to negative self-evaluations. So on this questionnaire here, the statements of the stigmatizing situations inventory, if you kind of like, assuming you may have taken a look at this before now, or even taken a look at it currently, the statements on here reflect explicit biases, such as children loudly making comments about someone's weight to others. They also reflect internalized weight stigma, such as a person assuming he or she is being stared at in public due to their weight. But one of these statements that I really would like to point out that's very relevant to our group and has been brought up several times is having a doctor recommend a diet, even if you did not come in to discuss weight loss. So, just, to kind of like think about, and I know we already have thought about, is there an underlying assumption that the person is binging or overeating, so they need to be on a diet? How is this person really perceiving, having a doctor recommend a diet, even though they didn't come in for that? And so is this really considered an experience of a weight stigma situation? And I think that would really depend on how they have internalized, weight biases. Next slide, please. So on this particular questionnaire, I also want to point out a couple of things on here. So there's one statement over to the right is number 1. No matter how much I weigh, I can do just as much as everyone else, which would kind of indicate or suggest that this person has a low or maybe no internalized weight bias. But there's other questions or statements on here. I feel anxious about my weight because of what other people may think of me, or whenever I think about my weight, I feel depressed, or I hate myself because of my weight, which would indicate a very strong internalized weight bias. Next slide, please. So I'm going to share 2 case examples, actually of patients of mine who gave me verbal permission to share this information. And so, I would just like for you to think about the types of biases that are in play or driving these situations. So the first case example, Miss S is a 31-year-old single white Middle Eastern woman who is a candidate for weight loss surgery, and her BMI is 40. Her diagnoses are depression, anxiety, night eating syndrome, mixed hyperlipidemia, polycystic ovarian syndrome, and obstructive sleep apnea. So she shared with me on one encounter that she went shopping, and the sales associate told her that they did not have those size clothes down here. You have to get those bigger clothes upstairs. And so she told me she ran out of the store because she couldn't breathe. So she was really having a panic attack. And she said to me, no wonder people with weight problems are depressed or want to commit suicide, which is really pretty intense. She said, I was so angry and embarrassed when she said this to me. I'm actually going to circle back to this case example here in a few slides later. So next slide, please. The second case example, Miss S is a 49-year-old single African-American woman who is a candidate for weight loss surgery, and her BMI is 66. Her diagnoses include major depression, post-traumatic stress disorder, psychological factors affecting morbid obesity, essential hypertension, prediabetes, chronic systolic heart failure, obstructive sleep apnea, knee and back pain, and osteoarthritis of the hip. So in a group setting, she shared that I've been on a diet my whole life. I could not eat what everyone else was eating. So, she was separated from other people. Like she was saying, these were her cousins. She couldn't eat what they were eating. I was told I was too big for my age. She stated that I am like this, and she was pointing to her body because of how I was treated. Eating was like rebelling against my family. Next slide, please. So in the last part of this presentation, I'm going to briefly review 2 non-pharmacological studies used to treat weight stigma and unhealthy eating patterns. So the first study is going to be one of acceptance and commitment therapy with mindfulness interventions and self-compassion interventions. Next slide, please. So this was a randomized controlled trial in a compared to treatment group. And a treatment group also was with treatment as usual. So if you were giving someone, appetite suppressant or whatnot, that was also included with the treatment group versus treatment as usual only. So the randomized clinical trial consisted of 10 weekly sessions, 2 booster sessions. And the aim of the study was to improve the quality of life of participants by removing weight self-stigma and correcting unhealthy eating patterns. Next slide, please. So just a very brief overview of the purpose of the intervention. A lot of it was geared towards education, de-shaming, reducing self-criticism, also helping them to develop a more flexible and accepting relationship with one's weight and eating habits. And also to tackle weight self-stigma, self-criticism, and increase motivation for self-care. Because I can't imagine, how hard it would be for someone to be motivated if they were very self-critical. Next slide, please. So compared to treatment as usual, the intervention resulted in an improved health-related quality of life, increased exercise from 1 time to 4 times per week, and a decrease in self-stigma about weight, decrease in self-criticism, unhealthy eating habits, a decrease in BMI, and general health problems. The self-compassion scores did not significantly increase between groups, and the rationale for that was that they introduced that concept too late in the treatment. Next slide, please. So the second study is cognitive behavioral intervention targeting weight stigma. It's another randomized controlled trial and consisted of 12 weekly sessions, 2 bi-monthly and 2 monthly sessions. And the intervention was cognitive behavioral therapy for weight-based internalization and stigma with behavioral weight loss. And then the comparison group was behavioral weight loss only. Next slide, please. So the purpose was to reduce weight-based internalization and improve coping with weight stigma. And they also used other measures to test psychological and physical health, whether those measures increased or decreased or stayed the same. Next slide, please. So they spent the first 60 minutes of the 90-minute intervention on self-monitoring, such as, keeping food diaries and following up on that, social support, education about stimulus control, such as where are you eating, what room are you eating in, are you eating while standing up or driving in the car, education about proper portion sizes, and helping them to develop school tools for setting goals. Next slide, please. So the last 30 minutes was spent on helping participants to, reduce this weight bias, this internalized weight bias that really causes, I think, a lot of problems in treatment and a lot of barriers in treatment. 2 points on here, 2 bullet points that I would like to focus on the relationship in the ABCD model, because, if you're not a psychologist and don't practice it, you might wonder, what is that? And then cognitive restructuring and reappraising stigmatizing situations. So I said, I wanted to go back to that very first case. And the case where here's the A. The A is the activating event. And my alarm is about to go off, by the way, because I'm trying to time myself. So the activating event was the sales associate making comments to the customer that those bigger size clothes are upstairs. And the beliefs, she had some type of negative internalized belief about weight herself based on her reaction. And so because she felt very anxious, she was panicking, she felt embarrassed. And then her decision, the D, what she decided to do, which actually, that's actually part of C, she actually decided to leave, but what we did in this model, the D model is considered, the D part of the model is considered dispute. So I said to her, well, let's kind of look at this situation, and talk about it. And so we did some reappraising of that situation. And so after we talked it through and helped her to look at it from different perspectives, she decided that the sales associate wasn't very good with her communication skills, and she needed some improvement in that. So she said, I'm going to go back to that store. I'm going to ask for the manager and say, hey, this is what happened to me. I think that some of your sales associate needs more help in learning how to communicate with, so that was the change, and that was a very good change for her. Next slide, please. So the findings, so both groups showed substantial reductions in weight bias internalization, and there were no differences between groups. Mood, body image, measures of eating behaviors, and self-monitoring skills improved across both groups, and with no significant difference between groups. The percent of weight loss was significant in both at week 26, but did not differ between groups. Next slide, please. And there were significant reductions in systolic and diastolic blood pressure at 12 weeks, but not at 26 weeks. There was no difference in cardiovascular risk between groups. And compared to the BWL group only, there were greater improvements on the weight stigma questionnaire total score at week 12, and on the self-devaluation subscale at weeks 12 and 26. And the significance of the reduction of score on the self-devaluation subscale is that it was important because that particular subscale captures individuals' tendencies to blame themselves for their weight. Next slide, please. So in summary, weight stigma, as was pointed out by Dr. Beverly, can increase risk for mental health problems and physiological problems. And as we can see, there are treatments available, but they're pretty sparse, and future studies are definitely needed. And I thank you for the opportunity to present today.
Okay, thank you, Danette. Any questions for Danette or Liz about their presentation before we go on?
So I do have a quick question for Danette.
Go ahead, Jim.
You talked about acceptance and commitment therapy and cognitive behavioral therapy. Are there brief skills that clinicians, primary care clinicians, can use with patients from the ACT model or from cognitive behavioral therapy?
Yeah, I would. So thank you for that question. It's a good question. One of the suggestions would be to perhaps even incorporate one of those questionnaires into their practice, so they're completing that before they come in and maybe take a quick look at it. And so then the intervention would be, maybe to take one of those points, especially if it's an internalized bias, and maybe just kind of talk about it and just very briefly, obviously, and then, try to reappraise or reframe how they're thinking about themselves, and because if they're defining themselves by their weight, if their weight goes up, they're negative, their weight goes down, they feel great, right? So, did I answer your question correctly or properly?
Yeah, that's a nice approach. Thank you.
Mm-hmm.
Thanks, Danette and Liz. So I just wanted to point out the corollary to Danette's, especially Danette's presentation. That's how we as healthcare professionals, not how we respond to internalized bias, but how we reduce our own biases, and what's been recommended by the National Academy of Medicine, and I was on their committee. So it has a lot to do with basic structural things, where you get a patient to undress and weigh themselves, for example, should be in a private area. You need to have the nursing or medical assistant staff not announce the weight, just not say anything after the patient has been weighed. Make sure you have gowns and chairs that can accommodate patients. It's extremely embarrassing for them if they're not able to be facilitated physically in your facility at all, et cetera. And the other rule that we established when I was a director of a pediatric center is to refrain from having any food or snacks in the clinical area, which is a big problem. To some extent, it sends the wrong message. A lot of us are busy and we'll grab something to eat here and there, but it certainly doesn't reflect well on us in trying to help people achieve a healthier weight. So just some recommendations that we came up with. Thank you, folks. Terrific discussion today. I'm going to turn things back to Jessie for a moment.
Thanks, everyone. I just have the usual quick reminder that you should have the post-clinic survey in your mailbox for today's session. So please continue to fill those out. And other than that, I think we're good to end a couple minutes early. So have a great rest of the week and we'll see you next Thursday.
Thanks, everyone. I am going on spring break for a couple days. So not me personally, but yes, I will be enjoying some spring break time. Take care, everyone. Bye-bye.